Hey everyone, welcome back. If you've just finished part 1, great. If you're just arriving, let me give you a quick recap. In part 1, we studied the full structural anatomy of the heart, cardiac wall, complete blood flow, external and internal structures, and all the valves. Now, in part 2, we're going to bring all that structure to life. We'll dive into the cardiac cycle and understand how the heart actually beats, how electricity propagates through it, how we calculate heart rate and cardiac output. We'll also learn about cardiac auscultation, an essential skill in clinical practice. Understand how the electrocardiogram works. Study the complete vascular anatomy of the body. And finish with the venipuncture techniques you'll use every day.
So get ready, because this is dense content and super applicable to veterinary practice. Each complete cycle of contraction and relaxation of the heart is called the cardiac cycle. There are two main parts, systole and diastole. During systole, the cardiac muscle contracts. Blood is ejected from the atria to the ventricles and from the ventricles to the arteries. During diastole, the heart relaxes and fills with blood for the next contraction.
Fundamental information. The impulse for the heartbeat comes from the sinoatrial node, the SA node. It sits in the right atrium and is the heart's pacemaker, a specialized cluster of cells that automatically generates electrical impulses. Let's understand the electrical mechanism. Some substances carry electric charges. Cations are positively charged atoms, sodium, potassium, calcium. Anions are negatively charged, like chloride. The SA node generates current through the movement of cations across the membrane. Cations are pumped out of the cell in the polarization process. When channels open, cations flow back to balance the charge. That's depolarization, and it generates the current that triggers contraction. Battery analogy. Like a battery has positive and negative poles, the cell membrane is also polarized. The difference is that a battery doesn't recharge itself, but the SA node repolarizes itself automatically and depolarizes again. That's why the heart naturally enters the cycle of systole and diastole.
The electrical current follows two routes, from base to apex. A fast route through specialized fibers of the SA node, AV node, and Purkinje fibers, and a local, slower route through the rest of the cardiac muscle. Unique feature: unlike skeletal fibers, cardiac muscle transmits the electrical impulse from one cell to another. Contraction spreads like waves in a pond after a stone. Skeletal muscle only contracts when it gets a nerve signal.
Importantly, the fast conduction of the impulse encounters a slight delay at the AV node. This delay is intentional. It allows the atria to complete contraction before ventricular systole starts. Without it, the high ventricular pressure would prevent blood from arriving from the atria.
After the AV node delay, the impulse accelerates through the bundle of His and Purkinje fibers. The fibers carry the impulse to the ventricular myocardium. Clever detail: the ventricles contract from apex to base, even though the impulse comes from the base. It's like squeezing a toothpaste tube from the bottom up. Efficient. When the ventricles contract, high pressure closes the AV valves. The relaxed atria fill from the veins. When ventricles relax, the aortic and pulmonary valves close. Pressure drops in the ventricles below the atria, and the AV valves open. Ventricles fill. SA node fires again. The cycle restarts. Now, fundamental concepts of cardiovascular physiology: heart rate and cardiac output. The heart needs to move the right amount of blood to perfuse tissues with oxygen and nutrients and remove metabolic waste. Fundamental equation: cardiac output equals stroke volume times heart rate. So CO equals SV times HR. Stroke volume is how much blood leaves per systole. Heart rate is how many times the heart contracts per minute. Practical example with a dog. If the heart ejects 2 milliliters of blood per contraction and the rate is 100 beats per minute,
The cardiac output is 2 milliliters times 100 equals 200 milliliters per minute.
Interesting. Horses and cows have lower heart rates than dogs and cats, but need higher cardiac output due to their size. How do they compensate? Higher stroke volume. Their heart is much bigger, so each beat pumps much more blood.
Vigorous exercise increases oxygen demand. The heart responds by increasing contractility, called positive inotropism, which raises stroke volume and increases heart rate too. Both factors together raise cardiac output. Starling's law. The more the heart fills, meaning higher preload, the stronger the contraction. A slight stretch of ventricular fibers increases contraction force. Atrial contraction sends about 25% more blood to the ventricles, triggering Starling's law. Important clinical example. Animals in shock have rapid, weak pulse. In hypovolemic shock, there's blood loss. In anaphylactic or septic, vessels dilate together, blood pressure drops, ventricles don't fill, preload reduces, stroke volume drops. To compensate, heart rate spikes. That's the rapid, weak pulse. The autonomic nervous system also influences. In fight or flight, sympathetic releases adrenaline, raising force and frequency. General anesthesia stimulates parasympathetic, releasing acetylcholine and reducing everything. That's why drugs blocking the parasympathetic are routinely given before anesthesia induction. Auscultation is listening to the heart. The normal cardiac rhythm is described as lub-dub. Lub is the S1 sound. Dub is the S2 sound. S1 is associated with the simultaneous closure of mitral and tricuspid valves at the start of ventricular systole. Due to heart position in the thorax, mitral is more audible on the left side and tricuspid on the right. S2 is associated with the closure of semilunar valves, aortic and pulmonary, at the start of diastole. Aortic is easier to hear on the left side. Interestingly, since the right ventricle wraps around the left, the pulmonary valve is also more audible on the left. Stethoscope positioning. In cattle and horses, you need to slide under the elbow. In small animals, caudal to the elbow. In large animals, you can also hear S3 from rapid ventricular filling and S4 from atrial contraction. S3 and S4 normally aren't heard in dogs and cats.
Since contractions are electrical currents, we can measure that activity with the electrocardiogram. It uses skin electrodes and generates the electrocardiogram, or ECG. The chart draws waves on paper as depolarizations and repolarizations happen.
The waves. P wave is atrial depolarization. QRS complex is ventricular depolarization. T wave is ventricular repolarization. Heart rate is the count of waves. If there are more P waves than QRS complexes, not every impulse passes from AV node to ventricles. That's heart block.
Vascular anatomy. Basic rule: arteries carry blood away from the heart. Veins bring it back. Systemic circulation blood is under higher pressure than coronary and pulmonary. The aorta is the largest artery in the body, with the largest diameter and thickest walls.
Arterial distribution. From the aorta come right and left subclavian arteries, going to the thoracic limbs. Depending on the species, subclavians give rise to right and left carotids, which run up the neck to supply the head. The aorta runs caudally below the spinal cord, branching to abdominal organs. At the pelvic limbs, it bifurcates into right and left iliac arteries. The coccygeal artery leaves the caudal aorta and supplies the tail. Arteries branch into smaller vessels down to the capillaries. Capillaries have very thin walls and no muscle. That's where exchanges happen. Important, in coronary and systemic circulation, arteries carry oxygenated blood and veins carry deoxygenated. In pulmonary, the opposite is true.
From capillaries, blood returns through venules, merging into veins. Veins have much lower pressure and thinner walls. Valves in small and medium veins ensure flow only toward the heart.
Venipuncture. Superficial vessels are used to collect blood, give IV medication, and place catheters.
In dogs and cats, the cephalic vein of the thoracic limb is used routinely. It runs between elbow and carpus on the craniomedial face of the forearm, carrying blood to the jugular.
In the pelvic limb, the femoral vein, more used in cats, and the saphenous vein, more used in dogs. The jugular is used in almost every species, runs in the neck beside the carotid. Caution in equids, don't inject sedative into the carotid, can cause seizures. In lactating cattle, the milk vein. In ruminants and rodents, the coccygeal vein of the tail.
We covered dense and important content, recapping the two parts. First, we understood the structural anatomy of the heart, from the layers to the valves and blood flow. Second, we dove into the cardiac cycle and the electrical impulse from SA node to Purkinje fibers. Third, cardiac output, shock, anesthesia. Fourth, auscultation and ECG. Fifth, vascular anatomy and venipuncture techniques.
In clinical practice, all of this connects directly with patient evaluation, exam interpretation, medication administration, and understanding cardiovascular pathologies. The cardiovascular system is involved in virtually every body function.
So keep this information, review the concepts, practice auscultation and venipuncture. Connect theoretical knowledge with clinical practice. Any questions? Come back and review the material. See you next time.